Dr. Hughes, I've thoroughly reviewed the patient's chart, and after looking at her past medical history and going through her first initial evaluation, I would like to talk to you about some concerns I have for the patient going through therapy and what I am thinking thus far about her condition. So right now, I'm suspecting that our patient has a somatic disorder, specifically conversion disorder. Somatic disorders account for about 80% of all physicians' visits. For our patient, Mrs. Jackson specifically, she just underwent a very stressful situation with her family and having her youngest child hospitalized with pneumonia. She also is showing focal neural signs of paralysis and blurred vision. However, all of her CT and imaging is negative for a stroke, which is what we would suspect as she came into the hospital with these symptoms. Currently, the patient is being affected with conversion disorder in both her musculoskeletal and neurologic systems. This means that this patient is going to be very challenging to treat. Throughout therapy, it's going to be important for us to make sure that we praise her strengths and her progress, that we gently approach inconsistencies, and that we ensure that we're progressing our patient by taking small steps and allowing her to feel confident as she moves through treatment. The patient also has a past medical history of Graves' disease. Graves' disease affects both her immune and her endocrine systems. The disorder specifically is from an overactive thyroid. It causes an overactive thyroid, and symptoms of this include tachycardia, hand tremors, fatigue, blurred vision, dizziness. And so throughout treatment, we want to really prioritize monitoring her vitals, heart rate, respiratory rate, blood pressure, as well as her RPE before, during, and after treatment. The patient also has hyperlipidemia, and because of this, the patient is at risk for developing atherosclerosis. This would affect not only her cardiovascular system, but also her circulatory system. Again, because of this, it will be very important for us to be monitoring the patient's vitals throughout treatment, as well as ensuring that we're progressing her appropriately through cardiovascular activity. Progress is going to need to be slow as the patient starts to increase both her intensity and her endurance capacity. Lastly, the patient has psoriasis, which affects her integumentary and her immune system. For this condition, we want to make sure that the patient is performing regular skin checks and that Mrs. Jackson has a proper steroid cream to use on the psoriatic areas. We also want to ensure that we prioritize mobility to reduce the risk of our patient developing psoriatic arthritis. Lastly, we want to make sure that there's no pressure that's put on the psoriatic areas, such as a gait belt, such as a waistband that's really tight, so that we can avoid irritating those areas if possible. Regarding the patient's medication review, the patient is currently taking Colace twice a day. She's taking Neurontin 3 times a day. She's taking prednisone twice a day. She's also taking simvastatin QD. And regarding the medications, I'm not too concerned about the patient taking Colace. Colace is an over-the-counter medication that's used to treat constipation, and an adverse reaction to this drug is unlikely. The simvastatin is a long-term medication that the patient is taking for her cholesterol. Because of this, the only thing on my radar is to be concerned and watch out for muscle pain. We need to make sure that if the patient is having any muscle pain, that we need to evaluate, is this due to the exercises that are making her muscles sore or hurt, or is this due to the simvastatin? The patient is also taking Neurontin, and I have a yellow flag and a little bit of concern when it comes to this patient's case because Neurontin can cause side effects of dizziness, it can cause blurred vision, it can cause many of the weakness and severe injuries, which the patient is currently presenting into the hospital. So I would like to make sure that the patient's symptoms aren't coming from this medication. If I suspect going through therapy that the Neurontin is causing any of the patient's symptoms, then I think that we should contact the physician to let him or her know and see if they would want to adjust our patient's dosage of that medication. The patient is also taking Lovenox, which Lovenox is going to put the patient at risk for severe bleeding with falls. Because our patient is already at fall risk, we want to make sure that we're utilizing a gait belt throughout treatment, throughout standing, balance, transfers, and ambulation activities, and that we're very much monitoring for this as the patient is at an increased risk for bleeding. The patient is also taking prednisone, which this is a corticosteroid and immunosuppressive drug. We want to make sure that the patient is not on this medication long term, as research has shown that longer than 3 months usage of this medication can cause or increase the patient's risk for osteoporosis. Lastly, this medication can make the patient more anxious. It can also cause the patient to possibly be at a decreased motivation to continue through therapy, and it can cause sleeping problems. Specifically, my biggest yellow flag for this case and concern is that the patient presented to the clinic with stroke-like symptoms. However, all of the imaging was negative. So because of this, throughout therapy, we would expect that the patient may show some reluctance to move her legs, that she may experience blurred vision, and we need to be able to modify, stop, adjust, change treatment if possible to meet these conditions. A red flag for therapy, then a contraindication, would be if we suspect the patient is having a thyroid storm. This can happen in severe cases of hyperthyroidism, and symptoms include nausea, anxiety, sometimes increased confusion, or even unconsciousness. If we suspect this, we need to refer the patient back to their primary physician and stop treatment. I also, in my mind, think that the patient is at risk for depression, which would give us some concern and caution to approach treatment. I would like for this patient to have a psychiatric evaluation so that we can evaluate how the patient's mental state is and figure out how I need to approach treatment, how we need to approach treatment better to meet her needs and concerns. If the patient is depressed and needs any additional treatment for that, we need to make sure that we approach proper members of the interprofessional team. I believe that in collaboration with the occupational therapist, the psychiatrist, the nurse, the physician, that I expect to see this patient return home in about 2 to 4 weeks. While research has shown that conversion disorder can completely resolve within 2 weeks, these patients are very challenging to treat, as there are emotional, mental, environmental factors that contribute more than just physical. As far as discharge from the hospital, I just want to make sure the patient is performing her ADLs, her transfers. Specifically, I want to see the patient do bed mobility independently in 3 to 5 days. I want to ensure that after leaving the hospital, Mrs. Jackson will then continue with outpatient therapy and return to a prior level of function, that I have a positive prognosis for our patient. Thank you.